officially live on Facebook.
Wonderful. Welcome, everybody. Thank you so much for being here. I'm Deanna Bryan. I'm Program Manager here at Hope for HIE. I'm joined with Betsy Pilon, the Executive Director of Hope for HIE. I'm sure she's a familiar face for many in this community. And with us today is Dr. Alexa Craig, a pediatric neurologist from Maine Medical Center and member of Hope for HIE's Medical Advisory Board. So Dr. Craig, thank you so much. We're so grateful to have you in honor of Epilepsy Awareness Month as we discuss everything seizures.
Thank you for having me.
Oh, thank you. If you wanted to take a minute and just kind of further introduce yourself, who you are, what you do, that would be amazing.
Sure. So where do I start? So I live in Maine and I practice neonatal neurology, and I love taking care of children in the neonatal intensive care unit here, and then for whatever their neurologic needs are after they go home from the hospital. My background for the research part of the work that I do is in telemedicine and trying to make sure that babies have immediate evaluations for, an evaluation for whether or not they meet criteria for therapeutic hypothermia. So that's kind of what my funded research is all about. And then I also run our cerebral palsy clinic here. Started it and have been running it probably for the last 5 or 6 years, with the changes that COVID caused. But anyway, that's a little bit about what I do.
Thank you so much. We're so grateful to have you, and we'll get started in just a few seconds. Before we begin, just another huge thank you goes out to our HIE community who shared so many wonderful, prominent questions with us. And are you ready to get started? Let's do it. We'll start with the basics. I think we're just going to start with kind of like a seizure overview. If you could answer and just explain, what are seizures?
Right. So I think that's the most important place to start, right? So that we all have like a common language and a common understanding of this really, really complicated topic. So having spent my career explaining this to families, I've come up with a really handy analogy. And my analogy is that I compare a seizure to a forest fire. And the reason that analogy really works for me is that everybody knows, especially with all the forest fires going on in the world right now, that a forest fire doesn't just spontaneously start. A forest fire has something that ignites it, whether it's a cigarette butt or a downed power line or, a lightning strike, something like that. And when that ignition happens, then there's sort of this like rapid, sort of like outbreak of flames that kind of spreads, right? So when we think about seizures, and particularly neonatal seizures, there can be something that ignites the seizure. And it's obviously not fire, it's electrical activity instead of fire. But that same idea of like something starting it, something that's irritated the baby's brain from lack of oxygen or blood flow or low glucose, or like there's a whole long list of things that can be the equivalent of that spark. But then this out of control electrical activity kind of spreads from that place to other parts of the brain. So that's what's happening, at the level of the brain, and we can see what that looks like on the EEG. What it looks like on a baby is very, very interesting, because for some babies, you can see some rhythmic movements of the, the opposite side of the body where the fire, kind of where the firestorm is sort of happening. And for other babies, especially for babies who've been given some medications to treat their seizures, sometimes the brain is having that seizure activity, but the body isn't actually doing anything. Those are called subclinical seizures. And we know that babies tend to have a higher amount of subclinical seizures than other older kids. So that's like my quick and, analogy-based answer to what is a seizure.
Yeah, that's so helpful. That's so helpful. And when it comes to measuring seizures, especially in the case of like a subclinical seizure, where, like you said, it may not have any physical manifestation, do we use EEGs to measure that? And if so, can you explain what an EEG is and what we look for on that?
So what I'm going to do is I'm going to share with share my screen with you guys so that you can see this really helpful website from the Neonatal Seizure Registry. So this is a research organization, and I really like this EEG picture that they put here. So basically, when we put an EEG on a baby's head, what we're doing is we're sticking electrodes. Most of the time, these electrodes are not needles, although on rare occasions they are. So these electrodes are just glued to the baby's head, and what those electrodes are doing is recording the electrical activity of the area of brain under the electrode. And so this is what an EEG looks like. Deanna, can you see this okay here on my screen?
Absolutely,
It
yeah.
works for sharing.
You.
So what I like simple and easy ways of remembering things. So you can see that there's some odd numbers over here, like a 7 and a 1 and a 3. So no offense to the left-handed people of the world, but the odd numbers go on the left side of the head because it's odd to be left-handed, right? There's many fewer left-handed people than right-handed people. And then the even numbers over here, or the red lines here, are on the right side of the brain. And so what this EEG is showing is that the left side of this baby's brain is kind of going along, and these little wiggly lines here are the brain waves, and these vertical lines are 1 second intervals. So this is what this baby's brain looks like. Here, the F is for front and the T is for temple. So that space right here is just wiggling along the way it's supposed to be, and the brain is super happy, okay? Now, if we look at the opposite side of this baby's head on the right side, this is not a happy brain over here. Can you see that the right looks totally different from the left? There's this like sparky, spiky, kind of like ugly kind of stuff. That's what a neonatal seizure looks like. So this slide, unfortunately, doesn't show us the start of the seizure. It shows us once the seizure is already happening. But what a seizure looks like on EEG is this, this kind of sparky, spiky activity that if I was able to scroll through this, you would see that it would probably kind of get smaller over time and then kind of just flatten out and go away. And that's what we would see on an EEG, whether the baby was shaking or whether the baby was, not showing us any clinical signs of that.
Interesting. And so like, I'm trying to think from a parent perspective, if I wanted to have my baby's seizure captured on an EEG, you can't obviously expect the onset of a seizure. So is there something called like an extended EEG, or I guess how would parents manage capturing that?
So lots of different answers to that question. So if we're talking about a newborn baby that came into the hospital because something scary happened around the time of the baby's birth, and the doctors were trying to decide whether it needed other therapy, probably they're going to put an EEG on that baby to see if it might be seizing as just part of its routine care because it's in the ICU and it's sick. And we would just be looking for seizures because we know that there's the risk there, okay? If you have an older kid, your older kid who you think may or may not have seizures, most likely what would happen in the outpatient setting would be that you would come in and your child would have, what we call a routine awake and asleep EEG. So it's usually a couple of hours. They usually, they take a period of time to put the EEG on, they record, and we really, really like to record the brain when it's both awake and asleep. And then they take the EEG off. So that might be like, 2 hours or something, depending on, all the time together to put it on and take it off. And then if we don't capture the information that we're looking for, there is something called an extended or an ambulatory EEG where we can put this stuff on and then we can send you home with it. And we can send you home with it for a day or 2 days or 3 days. There's another thing we do where we call it the epilepsy monitoring unit, where if we really have a spell we can't figure out, we can admit you to the hospital and we can put that EEG on and leave it running for many, many days to kind of capture the spell and see what happens. I want to tell you another quick part about my spark and forest fire analogy.
Yeah.
Let's say your child was in the NICU and then it does something, when the child is like 18 months or so that you think, oh, was that a seizure? Was that not a seizure? And you see a neurologist and you get an EEG, even if your kid doesn't have that episode, like doesn't do the same thing on the EEG is still very, very informative, because what we can do is we can look at the waves of the brain and we can kind of get a sense about the overall health and well-being of the brain. And we can also look for those sparks that start forest fires, okay? The sparks that would start the seizure. And that's really why we like to see the brain be awake and go to sleep, because sometimes those sparks are most likely to come out as that brain is transitioning in those two states. So if you get an EEG and your baby has none of those sparks, or spikes is what we call them, or epileptiform discharges is another word for that, and your baby or your child was awake and they were asleep in that study, that's a very reassuring finding that suggests that chances are whatever that funny behavior that you saw, chances are it probably wasn't a seizure.
Okay, that's so helpful. Thank you. If we could kind of transition now to a parent with a child with an HIE diagnosis, and
Okay.
they've been in the NICU for a while and they've just been discharged. I feel like there's a long amount of time that spans from that NICU discharge to the next meeting with a provider. Sometimes that span can be upwards of 3 months.
Yep.
That's a lot of time to not understand or know what's happening or what to look out for.
Right.
So what information about seizures should parents in that situation know in order to kind of bridge that gap between hospital, home, and then the next provider meeting?
So I think there's two distinct populations of kids we should talk about.
Okay.
One is the population of kids in the NICU who we thought, who had EEG and we were worried about, but never had seizures. Okay. They're a lower risk population, a much lower risk than a population of kids who had seizures and are going home on an anti-seizure medicine. Okay. So my dearest hope with all the work that I do as a neonatal neurologist and promoting this subspecialty is that families are not going home not understanding. To me, that's an absolute tragedy. And like my life's work is to try to change that. I know it's going to be slow work over decades, but anyway, that's terrible if that's happening to people. And I would love to find a way to, especially through an organization like this, to help advocate for families for getting information, before they're just home, like, oh my God, what's going on? So that's a bad place to be, number one. But number two, what are you going to be looking for? So if you are home and you don't have an appointment coming up with neurology for 3 months and you're worried about seizures, what I tell people, particularly if a baby was treated with therapeutic hypothermia and didn't have seizures, is that don't stay awake at night and don't stand there at the baby's crib watching the baby sleep. Okay. And I say this because I know parents who have been truly traumatized by their experience in the NICU, and they do one on, one off, and somebody's watching the baby sleep to make sure this isn't happening. If a baby did not have seizures in the NICU, it's low risk that it's going to have seizures in the future. Now, I wish I had this technology to sort of put my hand on the baby's head and predict the future. It's possible that a kid could have another genetic reason in the future for having epilepsy, right? So I can't I can't say there's no risk, but what I try to do for the families that I interact with is to very much take that level of anxiety and say, okay, it's really not here. It's really way down here. Okay. For the family that goes home on with a baby on an anti-seizure medication, the reason that family is discharged on a med is because the risk is thought to be high enough for recurrent seizures that we want to make sure that the child isn't going to have recurrent seizures. And so there a parent needs to trust that the medication is being given at an appropriate dose and is going to do its work. The other thing a parent should know is that babies with HIE, they tend to have seizures right around the time where the brain is injured. We tend to give the meds to stop the seizures, and then it could be years before they have another seizure. So I don't look at that 0 to 3 month time as a time where I'm oh my God, has it started yet? Is it, that's
Right.
not a time my level of worry is particularly elevated. Okay. If the child were to have a seizure, okay, so this is I think the rare circumstances, what is a parent going to see? And what I tell most parents is that it's going to look probably like the neonatal seizures that they saw if they were at the bedside when they happened. So some kind of a rhythmic kind of twitching movement. Okay. And the most important thing to know as a parent is that you want to be able to kind of put your hand on, let's say it's happening in your baby's arm, and that twitching is happening kind of at a frequency like what I'm trying to show here in the camera, kind of about a jerk a second. And if you put your hand on it and you can't make it stop, you can still feel it going, that's when you want to call your neurologist, or perhaps even call 911 first, depending on what the circumstances of your baby's breathing and everything else is.
Yeah, so if the movement can't be distracted or stopped in some way. Okay,
Yep.
that makes sense. I know there was another provider I was speaking to not too long ago who said she likes to very gently blow on the baby's face.
Mhm.
And sometimes that can act as a distraction too.
Yep,
like
right.
Snap them out of that movement.
Exactly. And that's a particularly useful for like a baby who's staring off into space and you blow and they're like, whoa, okay, I'm back.
Yeah.
You know?
Yeah.
So yeah.
That's very helpful. And that's the perfect segue into our next question, which is, babies move all the time and they have reflux and reflexes, and
Yep.
how it's hard, I would imagine, to discern the difference between a typical benign baby movement
Right.
and that of a seizure. So is that kind of your answer, like to see if it can be stopped or distracted, or is there anything else that a parent should look out for?
So one of the things that we're taught as neurologists is that if a child on one occasion does something funny with their eyes, and on another occasion it's something funny with their cheek, and on another occasion it's like their pinky finger and a toe, it's probably not seizure, because it's not like the same thing isn't happening over and over again. But if your child is repeatedly doing something that has the same kind of feel, like they turn their head to their left and their eyes like crank over to the left, and a part of the body is rhythmically twitching as that's happening, like the left arm is going, like that's probably a seizure, right? So it's all about kind of like almost like the reproducibility of it. Okay. The other thing is that babies jitter. Okay. So something that's like a fast, shivery kind of a frequency is very much less concerning than something that's like 1, 2, 3 instead of right. So this is a normal baby thing. And especially if the baby's cold, especially if a mom was taking a medication for her depression or anxiety, which I think all moms who have those issues should take those medicines, because they need to be the best mom they can for their baby. And this little transitory or transient shivering shakiness kind of goes away in the first couple of weeks of a baby's life. But that's something that we see sometimes that gets confused.
Okay. And then I am that mom. Like, just give it to me. I worry about everything. And so like in that position, you mentioned that if it's a rhythmic, sustained movement that can't be suppressed, what other moments do you think it warrants calling the ER, or making it more of an emergency situation?
So here's where I talk about something I call mom radar. I can't speak to the father's experience, so no, don't mean to be disparaging at all for dads. But I know when I had my first child, I have never slept the same since, ever. And I know that as parents, we hear things and we react to things because there's like this level of vigilance that we have once we become parents. I really think that parents make the right decisions, and they know when they're scared, and they go with their gut instinct of when they need to call 911. And my personal feeling is that should be a decision that's like made by your heart and your gut, and not like, okay, well, the doctor told me these 3 steps and I've got to go through these and figure it out. If you're scared, call 911, because that's what they're there for. Okay. If your baby's lips are blue, if your child's lips are blue, if you feel like your child is not breathing sufficiently, please call 911. Mm-hmm. And the thing to do, one of the most important seizure rescue things that we can tell people is to never put something in the child's mouth. Because if it's right to think that as the jaws clench sometimes in a seizure that they may bite their tongue. But what actually can happen is that if you put something in their mouth, you can make them gag and vomit, and then they can accidentally breathe the vomit, and that can cause a really significant injury to the lungs. So we really don't recommend that. We would recommend not putting anything in the mouth, and then actually putting a child in a position where if they did vomit, they were on their side, and so that the vomit would go towards the ground rather than gurgle in the back of their throat, so that their airway would be able to be cleared.
Yeah. And there are so many foundations out there too that offer certification courses in basic seizure first aid response. And that's something that, Betsy and we can link on this video as well for people.
Yeah. And most NICUs, I think, when they discharge families from the NICU, expect them to do some of those basic safety courses. At least my NICU does. We put parents through the video ringer and before we let them go home.
Right. Yeah. Well, I mean, you'd rather be over prepared.
Absolutely. Absolutely.
Our next topic is really now about seizure risk. And we've had so many parents in preparation for this Q&A mention what does epilepsy look like during sleep? They're very, and you kind of mentioned this before, don't take turns.
Right.
What does that look like, or what should we look out for epilepsy during sleep?
Yep. So I think this is, as a parent, one of the most terrifying things, right? Is that you want to have your kids sleeping in their own room. You want to be cultivating all those skills of independence for your child. And at the same time, you're terrified to not know what's going on. So what I would say about seizures during sleep is that they do happen. They are a risk factor for something called SUDEP, which I imagine you got questions about too, sudden unexplained death from epilepsy. What's the key thing to understand there is that it's frequent and uncontrolled seizures at night that are prognostic of SUDEP. Okay, so if a child has a seizure during sleep and they have one seizure, like, it's very, very unlikely that that's going to cause the demise of that child. But a child with a genetic epilepsy or a terrible, terrible brain injury for which we, with all the medications that we have and all the surgeries and all the things that we try to do, we still can't control the epilepsy, and that child continues to have seizures at night. That's a child who's at greater risk for some very scary and awful outcome. A seizure at night, for the most part, looks exactly like seizures do during the day, right? There's stiffening and they're shaking, and there can be oxygen desaturations. Most of the seizures that happen to people are relatively brief and self-resolving. I think that the things that we all get really scared about, like really prolonged seizures, they're unlikely to happen, out of the blue. Most of the seizures are going to be short-lived and self-resolving, or as soon as you get in there with your rescue medication, something like, rectal diazepam, that medication will abort the seizure.
Okay. Is there a point, because I know you mentioned that, like, if there's a child who went home from the NICU and maybe they didn't experience the seizure, that it's you can't promise anything, but it's unlikely that something would occur. On the other side of that spectrum, is there a point where a child has been having seizures where a doctor could be confident that that child will not have another one? Or does that not exist?
My guess is you're not going to get any of us to say with 100% certainty that you're out of the woods and you're never going to have another seizure. But what I will say is that the longer you go without having a seizure, the more optimistic we all feel, right? And then if you have a normal EEG without those spikes or those sparks on it, like, that's another, I always think a lot about what I do in neurology is sort of like accumulating evidence from the person's story into a bucket where either I'm feeling more reassured about things or a bucket where I'm feeling more worried about things.
Yeah.
So those are things that make me feel reassured that it's been years since like if a child had seizures while they were being treated with hypothermia in the NICU, the fact that they were recognized and treated with therapeutic hypothermia is awesome and prognosticates a lower chance of having seizures in the future than if they didn't get the therapeutic hypothermia treatment, right? Because that's protecting and helping the brain heal and recover. And so basically, we can't ever say, okay, you're in the clear, cross that off the list of things you have to worry about for your child, but the chances are diminishing over time, over time without seizures.
Okay. We have a couple more topics, and then just for people in the audience to know, Betsy is collecting all of the live questions, and that there will be time at the end to kind of sort through those. But for now, topic number 4 is all about infantile spasms, because that's something that we talk a lot about in the HIE community. So we have so many resources. Hope for HIE has done many Q&As and stuff about infantile spasms, and we can link all those resources, on the appropriate channels. But if you would briefly talk about what infantile spasms are, as well as kind of the signs or symptoms of onset, that would be amazing.
Yeah, and funnily enough, I've had 2 new cases in the last 2 weeks. Which
really,
yeah. So recently used data for me. So basically, what I think about infantiles, if you haven't figured out yet, neurologists think in buckets, right? We put everything in these groups. Okay, So there's a group of infantile spasms that occur in kids who have had some kind of a type of injury to the brain. We call those the symptomatic ones. And then the other bucket are the idiopathic ones, okay? And that means we don't have a readily available explanation for why a child would have developed those. The most common time for infantile spasms to kind of make themselves known is in the first couple of months of life. We usually think like 3 to 7 months, something along those lines. The earliest case I've ever seen was 2 weeks, but that was with a very, very specific and really significant genetic condition. So that would be extraordinarily unusual. It's much more likely after that 3-month visit with your pediatric neurologist. And what a parent would be watching for with infantile spasms is a new type of movement, and it tends to start around times when a child is either waking up or going to sleep. So again, that like all important transition of how, when the brain is going from awake to asleep. And what will start to happen is that the child will do some abnormal movements. And of course, I've got to demonstrate it, right? So the head will often drop and the arms will often extend and sort of stiffly for a second. And it may be quite subtle at the very beginning. And then over the following days to weeks, like you might look at it and be like, was that anything? I don't think so. And you just sort of brush it off. And then like 3 days later, you're like, oh my God, now it's happening like 3 times in a row, and when I lay the baby down to do the diaper change, just before they go down for a nap, they do like 10 of them in a row. And it will start to like pick up in intensity. So it will start to happen more times a day. It will start to happen for longer. Babies are often pretty irritable when it's happening. So they kind of like, they'll do that like kind of forward kind of that's why we call it spasms, because it looks like this kind of muscle spasm of the body. And then they'll start crying irritably because they're kind of like aware enough of what's going on, but to know that they don't like, I think anyway, that they don't like how this feels. I've never been able to talk to a baby to tell me exactly, but that's my interpretation. So that's what we look for that's how we would know that infantile spasms are starting. Now, in my practice, if somebody sends us a video, because we have it set up so that a parent can take a video at home and then email the video to us, we look at those videos and we will literally, as soon as we humanly can, like next day if possible, have that child come in and get an EEG to try to figure out, is it or isn't it, okay? And one of the big things that we're looking for is the background of the EEG. So instead of being those little wiggly lines that I showed you before, what starts to happen is that the background gets like really big and kind of like uncoordinated, and it doesn't have any organization to it. And then when the spasm happens, you can see this, we call it the decrement, and you see all the activity sort of kind of go away for a minute, and then that big chaotic stuff comes back. And so that clinches the diagnosis basically.
Wow. So this might be a dumb question. So EEGs look different based on the type of seizure being experienced.
Absolutely.
That's so interesting. Okay. Now, when it comes to infantile spasms, you kind of hit upon the importance of getting like an immediate response from,
right.
Okay. So once it is diagnosed, what is the course of treatment? This might be a huge question.
No, well, let me go back. Let me go back one step too, about the
Sure.
importance of that early response, right?
Yeah.
So we get lots of false alarms for spasms, and we would much rather get a video and be like, no, that's not it. And even get a video and do an EEG and provide a parent reassurance than miss spasms, because delayed diagnosis of spasms, they're harder to treat. So the earlier we can recognize them and know it's spasms and start the treatment, the better chance we have of making them stop, okay? And the reason that's so important is that EEG that I was telling you about, that's so chaotic and so disorganized. Left unchecked, that chaotic and disorganized EEG is there all the time, which means that your child's brain, who your child is kind of like going away, right? And so what we need to do is we need to treat them as soon as we can to make that chaos and disorganization go back to normal so that the kid is okay again, right? And so that the development continues. If we don't do that, the problem can be really significant developmental regression, so loss of milestones, a lot of irritability, and a harder to control seizures in the long term.
Okay. And
then
so
you said you wanted to know what the treatment was. So the treatment,
exactly. Yeah.
which is very peculiar. So there's very few types of epilepsy where steroids are the first line treatment, but for infantile spasms, this is the thing that works the very best. So families, depending on many factors that they would negotiate with their own neurology team, can be offered either steroids that are given by mouth or even steroids that are given by injection. Okay. And we try to use those steroids because that's the thing that we know that works best on this type of epilepsy.
Okay. And then obviously just conversations with with the
With the care
neurologist.
team.
Yeah,
Exactly.
Okay. Speaking of medications, why the choice to medicate for seizures? What is the benefit of it, and what does that kind of look like?
For infantile spasms or any kind of seizure?
I guess, you know what, we're going to go back to just we're going to avoid infantile spasms,
Okay.
and we'll just go back to the general conversation of
Yeah,
seizures. And I know you mentioned anti-seizure meds before.
Right,
too.
yeah. So treating infantile spasms is like a must do, because otherwise the developmental regression can be catastrophic. So enough said about that, right? Treating other seizures, this is a really interesting discussion. So there's a type of epilepsy called benign Rolandic epilepsy, right? Where most kids who get it, they're like, 5 or 6 years old. They have these funny nighttime seizures where they drool and they have some rhythmic movements of their body. And sometimes they have just a couple of seizures and that's all they have. And sometimes a family might say, the side effects that I read about the medicine sound really scary. My kid maybe has only had 1 or 2 seizures and I'm not convinced I want to be on a medication. And I think every physician should have a conversation with a family and try to meet them in a place where they're comfortable. So if you have a very low seizure burden, you can argue that the negative effects of the medication, they don't outweigh the positive effects. Okay. If you have a seizure disorder where, let's say, you seized for 30 minutes and you wound up in a helicopter life flighted from your rural community hospital to a tertiary medical center somewhere, and they put a breathing tube in you and you had to be on sedating meds for 2 days to make the seizure stop, that's a whole different kettle of fish, right? That is a situation in which clearly that child needs to be on a medicine every day so that doesn't happen again. Okay. And I'm giving you 2 extreme examples. Obviously, there's a multitude of things in the middle of that. And I just I can't in a talk like this, kind of make it meaningful for every single person.
Right.
But what I can hope is that people can have those kind of communications with their providers, talk very clearly about the pluses and the minuses of the medication. Another thing that comes up for us all the time in Maine, as a state that legalized marijuana first for medical uses and then for recreational uses, is should we just use CBD for literally everything? And, I have some pretty strong feelings about that because it's not an evidence-based therapy, right?
Right.
So there is a CBD drug called Epidiolex, which is, FDA approved and has very specific indications. But just like tinctures that people make in their, in their little, their labs, I don't know, and so I try to steer people in the direction of using things that are more controlled and more regulated and in my mind safer. But I have to recognize that not everybody thinks the way I do about these medications. So,
oh, of course.
Yeah. So it's a tricky topic. For the HIE community, for a child with seizures, most likely those seizures are going to be coming from one spot in the brain where some injury might have happened. And probably your doctors are going to recommend one of 2 first-line medications, either levetiracetam, which its trade name is Keppra, or something called oxcarbazepine. Its trade name is Trileptal. And those are our go-to first-line meds because they're both available in liquid. They taste pretty good. They're easy to give to small children, and they're really safe. So, yeah.
At what point when are medications usually prescribed? And then is there a point where you start to have the conversation of weaning a child off of those meds?
So this is something I meant to say earlier and got sidetracked, but there's a distinction between a seizure and epilepsy. Okay,
Right,
so a
right.
seizure is an event where you had this forest fire of activity in your brain. When you have epilepsy, the definition of epilepsy means you keep having forest fires, right?
Right.
And the definitions change. So, it used to be that you had to have a couple of them. Now, if we do your EEG and we see a lot of those sparks, we say, well, you've had a seizure. We think there's a really strong chance you're going to have another. We can call that epilepsy as well. So, those are kind of like the distinction between those two terminologies. And we tend to start a medicine once we think that a person is having frequent enough seizures or, epilepsy, so that risk-benefit ratio is in favor of having the drug side effects outweigh the side effects of the seizures, if that makes sense. And then to wean them off, let's say we start you on a medicine. I picked the right med for you the first time, and you don't have another seizure for 2 years. That's kind of usually what we look for. And we all are like super, super happy, and we celebrate, and we think about it 2 years weaning the medication off. We never cold turkey stop it. We usually stop, take it off over a couple of weeks. And it's not a guarantee that the seizures are gone forever. Sometimes I've gone slow weans and kids have started seizing literally the day after they come off the medication. And sometimes we take somebody off and they never have another seizure again, so it's very, God, I could be so, like, if I could predict if I could create the technology to predict which group somebody would be in, it would be amazing.
Yeah. Now, correct me if I'm wrong, because I know you had that great analogy about seizures and forest fires.
Yep.
Did you, in our preliminary conversations, did you also mention that you have an analogy for like meds and what their side effects are, or did I make that up?
No, you didn't make that up at
Okay.
all, Deanna. It's actually the
Okay.
continuation of the forest fire analogy. So
Yeah.
thank you for circling back to that. So if a brain has injury from an HIE event around the time of birth, and if that part of the injured brain is having sparks in it, I can't make it stop. I can't send a medication exactly to that spot of the brain, right? So what we do is we send the medicine to the whole body, okay? And the whole brain as a consequence. And I like to think of the medicine as kind of working like a fire extinguisher, right? You sort of spray down the whole brain with the fire extinguisher, and it makes it so that even though that part of the brain is sparking, it can't capture the rest of the brain into the forest fire. Right. And so it's a really good analogy. It explains how the medicine works. It also explains the side effect of the medicine, right? So some of our older drugs, like phenobarbital, for instance, is a great example. When we give phenobarb on an everyday basis, which we really don't do very much anymore, but was done when I was a kid, that medicine has like a big fire retardant effect on the brain, and children are sort of lower tone, kind of slumpier and kind of sleepier, and like, it's because that medicine is affecting the whole brain as opposed to just being really focused on that part that's discharging abnormally.
Yeah. You mentioned before already the impact of seizures and even infantile spasms on development.
Right.
And I know there are so many questions in our community that ask, like, how might development be impacted?
Mm-hmm.
And what should parents look out for in terms of regressions or milestones not being met? We'll start there because I could go on.
Right.
It's a big question.
Yeah. So this is a huge question, right? So
yeah.
I think like the textbook answer is that if your child has, just a regular seizure of a couple of minutes duration, that all by itself is not going to have a massive effect on the child's cognition, that you could do an IQ test before, and you could do an IQ test before, and you could be like, oh my God, it's lower now, right? Mm-hmm. If your child has uncontrolled epilepsy and has big seizures every day for many months, absolutely, again, going back to this fire, kind of analogy, if you have like an out of control forest fire in your electronic circuits every single day, of course, it's going to take a toll, and it's going to make the circuits not work very well. We call that epileptic encephalopathy, which is a huge kind of big term, but epileptic, of course, relating to the presence of epilepsy, and then encephalopathy, meaning the brain isn't working particularly well. Those two things absolutely happen. Okay. But again, it's based on the burden of how much seizure activity there is. So I think if a child has one seizure or two seizures, often parents will report they take a few days to weeks to kind of get back to their baseline and to get back to completely normal, but they should get back to completely normal. It's that uncontrolled seizure disorder where kids are then sort of losing milestones. And what you also have to kind of like think about at the same time is that if your child had HIE and your child has epilepsy, is there another process such as cerebral palsy at work, which could be more responsible for a child not meeting developmental milestones than the seizure burden, right? Because if the muscles of the arms and legs are stiff and tight and not allowing a child to like learn to crawl or learn to roll over or do those motor development things, that may well have not a lot to do with the seizure activity other than the common injury at the start, right?
Right.
Right.
And I guess it goes back to obviously important conversations with the care team, but even early intervention, which is something that Hope for HIE is trying to kind of bring more awareness to, are these early interventions and therapies that states provide.
Absolutely.
Yeah. Okay. Wonderful. Yeah. We just have one last question, and then we'll open it up to Betsy and Q&A. Awesome. Overall, do you have resources that you like or appreciate that you often share with parents with children who suffer from seizures and or epilepsy?
So the one that I go to the most or send families to the most often is Epilepsy.com. What I really like about that website is that it was written by medical professionals, but they take the language, away from our annoying use of 3-letter abbreviations and like the over medicalized stuff. So it's like the same content, but it's at a level that's accessible for regular people. And so, I would definitely put a plug in for that website, because I really, really think, there's this big menu on the left and you can look at all the different types of seizures and you can learn about the meds and the side effects and EEGs and like all sorts of stuff there that really covers like everything.
That's awesome.
Yeah.
And and there's so much information out there and it can be so overwhelming. And sometimes it's hard to discern like what's a reliable resource and what's not, especially when you don't have that medical background.
Exactly.
Which is something that I've even just been learning and researching this whole process. It can be hard. So, getting validation from you that that's a good website, that's huge.
Awesome. Good.
So I'm going to turn it over to Betsy now, and she's going to kind of handle the live questions that have been coming in. But just on a personal note, thank you so much for talking.
My pleasure. Thank you.
Answering those questions. And Betsy, do you want me to turn off my camera, or am I?
Keep it on if you want. That's
fine. I'll keep it on.
Fantastic. All right. So yes, I will say the chat has been very, very active. I'm not shocked, because epilepsy is probably the biggest burden on our community. And there's always questions about, especially kids that had neonatal seizures and what it might look like later in development, and everyone wanting a crystal ball. So, which unfortunately we still don't have, as you mentioned earlier.
Yes.
But there were two questions I think we want to elevate, of those that I wasn't able to, either point to another resource or, just general things that we have shared before. So one is about EEG follow-up. And so, we know that this is going to vary, but what is, so the question came from a parent whose child, has not had any seizures since the NICU. And, what is the standard, follow-up of, when you might look at doing a repeat EEG?
So I don't think there's a guideline for that. So I think what you're going to find is that it is very specific to the practice style of whoever's providing care for you. I personally do not routinely do tests unless I have a really strong feeling from the clinical story of the family that I'm going to get something actionable out of the test. And the reason that I don't do that is, let's say I put an EEG on a kid who isn't having seizures, but, had an EEG in the NICU, and we just sort of want to see what's going on. And let's say that kid has some sparks on the EEG. Well, now what do? Do I give the kid a medication that's going to have the side effects like the fire retardant and dampen down that child's brain? No, like that's not evidence-based. People shouldn't do that. So like, what's the use of knowing that there's sparks there? And then I think you could argue, well, then the parent would know to watch for seizures. But the thing is that there's not a perfect correlation between having those sparks and having seizures. I've never had an EEG. I'm sure, well, who the hell knows, but maybe my brain sparks. I don't know. So like, it's very, very hard information to have. And then, what I often think about a lot about what we do in medicine is like, are we harming or are we helping with the knowledge that we have the ability to get, but we don't know what to do with? And so I personally try to not get those studies because my opinion is that they tend to be more harmful than helpful. There's one exception, which is that if a child has had injury to a part of the brain called the thalamus, which is the deep central structure to the brain, if there's been a stroke or injury to that part of the brain on an MRI after cooling or after, if the baby wasn't recognized for cooling, when the MRI happened in the NICU, that's a child that's at risk for something called ESES, or electrical status epilepticus of sleep. Another scary thing to read about if you want to stay up at night. Doesn't tend to happen in our population. It tends to happen in kids with injury to the thalamus. It doesn't tend to happen in kids without injury to the thalamus. But that's a kid, if there is that injury, that I will repeat the EEG probably once a year or so from like 3 to 6 or 7, something along those lines, because that's a very hard epilepsy to recognize otherwise.
I am so glad that you brought that up. And something, that people should be aware of with HIE is we are a leading cause of many of these rare epilepsies, unfortunately, and that in particular, ESES.
Yeah,
you brought up. We've seen a lot of kids who might have a more mild impact from their HIE who end up getting diagnosed, around that school age.
Yeah.
And we're seeing that, I know that the science has moved forward and continues aggressively in this topic as well. And as well as, there's clinical trials that some of our families are in for that and things like that. So there is always hope for a lot of these, epilepsies that are, and difficult and could be, developmentally impacted. And I know you mentioned, that as well. And I remember education as well when, asking about this myself of, what impact does a seizure have on a child? And you talked a lot about that before, of that, typically the average, I guess, seizure might not have that developmental impact, but certainly some of these other rare ones may.
You couldn't have said it better. Like these, like ESES and infantile spasms are like 2 prime examples with profound impacts, honestly.
Yeah.
Yeah.
All right. And one of the things that we didn't talk about with medications is that there's other options that might be suggested to control epilepsy. So keto, the keto diet, which, I would love for you to speak a little bit about that.
Yeah.
There's also a movement of, and not necessarily, I think, as often with our community, but certain in other kids, different options with epilepsy surgery and things like that is not like our last resort, and looking at that tailored, precision-based medicine depending on the child instead.
Right. Yeah. So absolutely, it's guided by the child. So when you start to look at options like ketogenic diet, vagal nerve stimulator, epilepsy surgeries, taking a piece of the brain out that's making those sparks, those are all for kids who have what we call intractable epilepsy. And so that intractable definition means that you've had 2 or more medications at therapeutic doses, that you've tolerated those medications, but we have not been able to medically stop your seizures. And so that's when we think about escalating to these other options. Ketogenic diet is something where, if I remember correctly, I think it's 90% of your calories come from fat. So if you're an infant, we can give you something called KetoCal, which is a really high, super high fat formula. And especially if you're a child who is fed by a gastrostomy tube, that can be a relatively straightforward treatment for epilepsy. There's a whole lot of blood work monitoring that gets done to make sure like all the levels of the triglycerides and all these like micronutrients and things, that those are all staying in the right balance. But it can be a really effective therapy. So the numbers that we're usually taught to sort of tell parents is that for, each sequential medication we add has a lesser and lesser and lesser chance of working, right? But then when you come in with like a ketogenic diet, it might, decrease, it might like help the epilepsy, like substantially help it like by a factor of like 30% or something. Mm-hmm. And so it's a much more, for that intractable kid, it's a much more appealing option. Vagal nerve stimulator is an implantable device. I always say to families, it's sort of like what do old people have?
Pacemaker.
Pacemaker. Thank you. I could not find that word. So it's like a pacemaker, and it has a wire that's attaching to one of the nerves, and it's sending a signal to the brain on that nerve to kind of like calm the brain down and tell the brain to just stop having seizures. And for certain types of epilepsy, that can be really, really effective. And then the surgical options, I am by no means qualified to talk through all of those, but they range from like a lesionectomy, where we've identified a malformation in your brain, and we're just going to take out the thing that's making the sparks. That can be really effective, all the way to something else where, the corpus callosum, which is the big kind of highway that kind of connects the two hemispheres of the brain. Some surgeries disconnect that, they cut that so that the two sides aren't talking to each other anymore. And that can be an incredibly effective solution. But these sorts of surgeries should be performed in epilepsy centers of excellence, where they're really taking care of a lot of children and, doing things that are evidence-based and not just, well, let's try this, this is a big deal,
And there's a wonderful resource called the Brain Recovery Project. That is another resource out there for epilepsy surgery. So we'll link that as well for anyone that wants to read up on that. I think that is the last of our questions that you haven't answered. Yay. So this was just incredible. Anyone that has been in the chat and asking additional questions, if I'm not asking Dr. Craig right now about it, it's because we have a resource, and I'm going to connect that link to you afterwards. This video will be available after this live is over, forever in perpetuity. So no pressure. Yeah. But it's so wonderful. So you can go back on your own and view it at any time. So if you have missed half of it or parts of it, or you were asking to repeat something, you'll be able to go back and review that after this is over. So I just want to thank, on behalf of all of us, for your participation today, for all you do for the families that you take care of, for serving on our medical advisory board. It has just been an incredible time today. Deanna, you rocked it today. Thank you for doing your first Q&A.
Oh my God, she totally rocked it. Yeah, that was.
I have a background in theater. Can you tell?
Yeah.
So thank you everyone who has been watching, and we will see you next time.
Yeah.